Much. I thank all of you for inviting me to this. So, Dr. Tinku Bali has given us a very good overview about what to do and what not to do in a case of a PC rent. And finally, I will be talking about once the inevitable has happened, now what are we going to do? So one thing I want to suggest would be that all of us retinal surgeons will have different techniques. We are having certain small differences in our this thing. So you should talk to your referring retinal surgeon whether to put the lens, whether not to put the lens, etc., etc. So that is one thing. Now let us just go into nucleus drop. Incidence is about 1%, but anyone can get it at any point of time, even though the novices and the learners will have more chances of getting it. What are the predisposing factors? Hard cataracts, posterior polar cataracts, previously vitrectomized eyes in which there may be some capsular problems. So either the whole lens can get dislocated, or maybe posterior subluxation can occur, or a fragment can go down. The basic problems now are the expectations after a cataract surgery is so high. Less than 6/6 is not acceptable, and many people take up for surgery just less than 6/6 also. So a vision of 6/12 or 6/9 post cataract surgery is absolutely unacceptable in the practice which is right now, and that is why it is very important. Now we will get a general idea of the hardness of the nucleus by doing an ultrasonography. Like here the interior echo is less, whereas here it is more. Now CTR is a very common accompaniment now. Many people use CTR in a dislocated lens which we find on the table, and care should be taken that the CTR also don't dislocate down, because it's a very difficult thing to take it out. Now, two things which Dr. Tinku illustrated once. So this is using a needle to lift into the vitreous, or again using a needle to hook the lens. So any physical elevating maneuver within the vitreous without removing the vitreous is a dangerous technique. Okay. Now this is the nucleus drop. So a person is phacoing, and suddenly what happens is the nucleus drops down. Okay. So do not panic. That is a mantra. Do not panic. Call your friendly VR surgeon. You should have one. If you don't have, make one. Anterior vitrectomy, as was illustrated. Remove vitreous from the anterior segment. Don't fill the anterior chamber with visco and leave. That is one terrible mistake which I almost always find, because you increase your viscoelastic. You think that the cornea is going for a 6, so you put viscoelastic in the anterior chamber, put a tight suture and leave. Next day the pressure is 50. You can place an IOL in the sulcus depending upon your VR surgeon's advice and secure the wound well. Do not panic. Do not use any blunt instruments. Big phaco-masters do posterior visco-assisted levitation, but not ordinary phaco-surgeons or bigger than ordinary phaco-surgeons. Okay. So post-op management, because it is a longer surgery than usual, systemic antibiotics can be given, systemic steroids to clear off the cornea, etc. Look for reaction IOP and corneal status. Should you remove all the fragments? Almost always. See, even the smallest of fragments can cause a cystoid macular edema. It can rise the intraocular pressure. It can cause certain amount of uveitis which will be there for a long period of time. So generally, all fragments should be removed. What are the techniques? Vitrectomy probe can be used if they are very soft and small. MVR to pierce and remove, which is no longer used now. PFCL levitation and phaco-fragmentation. These are the common things that we use. This is anterior segment management. Dr. Tinku has elaborated on that. I am not going into that at all. Okay, now this is a lens. This is entangled in the anterior chamber. So you have to cut all around so that the attachment of that lens to the surrounding anterior segment structures will go, and then slowly the lens will sink down. And then once in the vitreous, we have to take care that the vitreous around that lens is first cleared. So here we are seeing that the lens is slightly stuck here, and you have to probably disengage the vitreous here in order for that lens to come down. And once the lens is down, we are basically cutting all around the vitreous. We are not touching the lens at all. We are just clearing the vitreous all around. So that is an important thing, so as to make the lens an independent unit within the vitreous cavity, so that there is no adhesion with vitreous on any part of the lens. Then entry for a phaco-fragmentation. Unfortunately, even though we use all micro-incision vitreous surgery, the phaco-fragmenter is still large. It is about 19 to 20 gauge. So you have to enlarge that incision to put the phaco-fragmenter in. Okay, so this is a phaco-fragmenter being entering into the eye. Then first step once we go in would be to remove the epinucleus, so that the nucleus itself becomes smaller in size. So the epinucleus is very simple to remove. You do not require any phaco power. You can just with suction remove the epinucleus. So this is epinucleus removal. So all the surrounding with the vitrectomy probe and also with the phaco-fragmenter, you can remove the epinucleus. Okay. Okay, now PFCL cushion can be used. I'm sorry that this video is not working. PFCL cushion can be used before you perform a phaco-fragmentation, because sometimes when you do a phaco-fragmentation, the fragment will go and hit the retina again and again and again. So to prevent that and from traumatizing the macula and the disc, you can use a PFCL cushion before doing that. Yeah, so here we can see a PFCL cushion. You can use a single-handed or a bimanual technique for removal with phaco-fragmenter. Here in the left you can see a single-handed removal, whereas here you are using the illuminator to crush the fragment into smaller fragments, and on the other side you can see the phaco-fragmenter which has held the lens very tightly. So you could use a single hand or a bimanual, whichever you want. And if you want to use a bimanual technique with a sharp instrument on one side, then you can put a chandelier illuminator and do the same, so that your both hands are free. Now the large fragments, the trick is always to bring the large fragments into smaller fragments, and then the smaller fragments can be easily emulsified. So that is a trick. So don't try to emulsify large fragments, because you will end up spending a lot more phaco energy in the vitreous cavity than what is normal. So the trick is to reduce the size of the fragments and then to take the fragments. The very last bits will easily come out. And that will be the end of that will not be the end of surgery, that will be the end of phaco emulsification procedure. Okay, the last end of surgery, you have to induce a PVD and complete the periphery. You have to look at the periphery to see if you have created any breaks, whether there are any pre-existing lattices, whether there are any traction, etc. So PVD induction is the last technique. Now sometimes if the nucleus is very hard, which these are about 8-year-old videos, then you take out through the limbus. These are large nuclei which are taken out through the limbus. Okay, which most cases now with our improved phaco-fragmentation mechanics, we are able to phaco-fragment. So IOL implantation is done. Anterior chamber IOL, or Avninder Gupta will just describe to you how good an IOL can be put in these situations without PCR support. At the end of surgery, you are taking out the infusion and everything is fine. So that is about vitrectomy. So what is the timing? So if you have VR setup right in your OT, then immediate timing can be very suitable, because the patient will not even come to know that there was a major complication which occurred. But otherwise, it is always better that you wait for a week, probably to reduce the inflammation, reduce the pressure, reduce the cornea will become much more clearer. Okay, so after that you have the option of doing the vitrectomy. Immediate day 1 vitrectomy versus day 7 vitrectomy does not have a huge impact in the visual prognosis. But one thing that we have to do is to discuss honestly with patients. Complications do happen. Don't need to be guilty, because it is a 1% incidence at the best. Not at the best of hands. It is a cumulative 1% incidence. So I would borrow Dr. Lalit's slides. Sunk nucleus is not sunk eye. Retinal surgery with very good prognosis, better than 612 in 75% of patients is what it was. But if the anterior segment surgeon has tried to fish the vitreous or try to fish the lens out of the vitreous, then there could be drastic complications which will skew our results very badly, because giant retinal tear, dialysis, retinal detachment, subretinal nucleus, all this is possible. So dislocated lens with foreign body, dislocated lens with retinal detachment, choroidal detachment, vitreous hemorrhage, endophthalmitis are more complicated situations which require individualistic approach. Thank you very much.